We can start now.
Start, sir?
We can start now. We can start now.
Yeah. Good evening, everyone. On behalf of Allergy Applied Chapter, I welcome all of you. Very important webinar, particularly biologics and allergy. Very important topic. The future medication for all allergy disease. I think this is moderated by Dr. Dhanesh sir, and I welcome first our chairperson Neeraj Gupta sir. Neeraj sir.
Thank you, Reddy sir. So good evening, everyone.
Start now. Start, sir.
We can start now. We can start.
Yeah.
So good evening, everyone.
Good evening, everyone. On behalf of Allergy Applied Chapter, I welcome all of you. Very important webinar, particularly biologics and allergy.
Good evening, everyone. It gives me immense pleasure to welcome you all to the launch of our biologic webinar series, which is hosted by IIP Allergy and Applied Immunology chapter. We stand today at the threshold of a therapeutic revolution, which is the biologic era, which is transforming how we manage the allergic diseases today. From blocking the IgE antibodies to now targeting the newer interleukin pathways, biologics precision and hope to patients with severe or refractory allergies. This 3-day series is designed to take us from the science and indications to real-world applications and then to emerging frontiers in biologic therapy, all with a focus on the Indian context. I thank our esteemed faculty, moderators, and our engaged audience for joining us in this educational journey. Together, let us embrace these innovations with responsibility and reason and advance the care we offer our patients. Let the series begin. Thank you.
I think today moderation by Dr. Dhanesh is treasurer of Allergy Immunology chapter, and therefore I request Dhanesh to introduce the speakers. I think this biological is going to be like a surgical strike, Operation Sindhu, like specific targeting treatment for allergy disease, future management. So I request Dhanesh to introduce all speakers and start the session.
Thank you, Reddy sir and Dr. Neeraj. So we are here for a biological yeah. It may not be a weapon, but we will definitely use it. Everybody will be eagerly waiting to use it and wanted to know it. And exactly all the problem will be solved. And we have got the best of the expert available in the country from Dr. Shalini, Dr. Karthik, Dr. Sunita, and Deepak Talwar, sir, who is one of the major persons of biological in India. So please remain with us for the next 2 hours, and within the constant of time, by 10 o'clock, we'll do all this program. And so we have about 25 minutes for every talk, and we can take the question and answer in between after every talk. And if all the speakers remains, then we can take at the end also. And I request all the speakers to remain at the end so we can answer lots of queries from everyone. So to begin with the today's seminar, the first talk will be on basics on mechanisms and molecular targets in allergy, and this will be given by Dr. Shalini Tegi, who has got an immense experience in managing allergy. Um, and she's at the moment working with the Metro Multi-Specialty Hospital in Noida. Over to you, Madam Dr. Shalini.
Thank you. So while I share my screen, I am given the task of finding the terrorist outlets of Operation Sindoor. So the targets. So that is why my job is to start with the basics. Please tell me if my screen is visible.
Yeah, it has come, madam. Make a full screen.
And the slideshow is on, right?
Yeah, from beginning you can make.
Yeah, thank you.
Yeah, it's up.
Thank you. Perfect. So talking of biologicals, first we look at the mechanisms of allergy. We all know the concept of sensitization, early phase and late phase. The thing that I wanted to highlight was in sensitization phase, the most important antibody is IgE production, pathway of inflammation. And in the early phase, the cell involved is mast cell, which releases mediators like histamine, prostaglandins, and leukotrienes. And the late phase, the cells involved are eosinophils and neutrophils, and the mediated released are leukotrienes, cytokines, and chemokines. So this is essentially the pathway that happens. So apart from IgE antibody, which is the crux of Th2 type hypersensitivity reaction, the most important mediator of inflammation which can be targeted, there are certain cells involved and most of them have been studied. The mast cell, eosinophils, Th2, Th17, basophil, neutrophils and platelets, and there are structural cells as well. They work through multiple mediators which are cytokines and chemokines, and that leads to effects on the body which gives us the symptoms of asthma, allergic rhinitis, sinusitis, etc. and AD. Apart from out of these multiple targets, the commonest studies are IgE antibodies, the receptors of IgE antibodies, the cells, cytokines and chemokines, and let's talk about them one by one in my presentation. So whenever the allergen enters into the body, it binds to the mast cells by cross-linking the IgE antibodies. The first thing that it affects is the IgE antibodies. These mast cells release bronchoconstricting mediators, which are leukotrienes and prostaglandins, which affect on the muscles to cause bronchoconstriction. Epithelial cells release SCF, which is important for the mucosal airway and the skin surface, as well as allergens are processed by basophils and the dendritic cells with the help of TSLP. This TSLP is secreted by epithelial cells and mast cells. So this is the second target which can be worked upon. Allergens are then epithelial cells then secrete CCL17 and 22 and induce the CCR4 to bring the Th2 cells into the inflammatory cascade. These Th2 cells, with the help of interleukin 4 and 13, and continue the inflammation process by recruiting B lymphocytes IgE production as well as further Th2 cell stimulation. So the next targets are interleukin 4 and 13 as well as the receptors through which they bind to the Th2 cells. These Th2 cells also secrete interleukin 5, and interleukin 5 is the most important cytokine for eosinophilic inflammation, for recruiting the eosinophils into the environment of inflammation. So interleukin 5 becomes our next target, and interleukin 5 binds through the interleukin receptors on the eosinophils, which is another target which is looked at while we work on the molecular mechanisms. Let's take them one by one. So this is the immunoglobulin E, which is produced when the pollen enters and there is a sensitization. B lymphocytes convert into plasma cells and secrete multiple immunoglobulins which go and rest on the mast cells. Now, when there is a second exposure by the pollen, these IgE antibodies on the mast cells are bridged by these pollens and multiple mediators of inflammation are released. So IgE and its receptor, Fc epsilon receptor, are the beginning, the gateway. They open the inflammatory process, and that is what we can target. At the level of the antigen presenting cell, the IgE is bound to the APC, and there is a receptor, that is Fc epsilon receptor. The allergen is internalized through this receptor and IgE, where it is processed and then it is presented on its surface with the MHC class 2 molecules. The MHC class 2 molecules are involved in activation of the Th2 type cells, which are Th2 CD8 cells. At the level of the muscles, these IgE antibodies are displayed on the surface. They're attached on the surface, and when the allergen bridges these two IgE antibodies, it leads to beginning of cascade of inflammation and release of multiple mediators from muscles, which are prostaglandins, leukotrienes, histamines, and cytokines. And these are involved in allergic inflammation. Now, have a look at the T lymphocytes. There is always a Th2 versus Th1 preponderance in allergic inflammation. T regulatory cells have inhibitory effect as well as Th17 have pro-inflammatory effects. Then we have Th9 cells that secrete interleukin 9, which is important for mast cell differentiation. And apart from this, there are basophils B epsilon cells, which are involved in secretion of IgE by the help of multiple receptors on its surface. Mast cells and basophils are crucial effector cells in allergic reaction. There are H1R and H4R receptors are present on these cells, and that's how our anti-allergic medications work on preventing the allergic reactions. Multiple cytokines like interleukin 4, 5, 14, they are produced by the inflammatory cells. The interleukin is one of the very important identifiable allergic inflammatory cell. It is there in the asthmatic lungs, allergic nasal passages, defining it as a typical allergic cytokine. It is produced by multiple cells, which are T helper cells, basophils, eosinophils, mast cells, and natural killer cells. However, basophil and eosinophil has it in a preformed granules, and they're very easily released by these cells upon stimulation. Interleukin 4 works at the level of B cells activation. It increases the MHC2 receptor and multiple receptors on the B cell, making it more pro-inflammatory. It promotes the antigen presentation, and it drives the IgM to IgE isotype switch. And it also enhances low affinity IgE receptor expressions on the cells. It also works at the level of T cells. So apart from B cells, interleukin 4 promotes the Th2 phenotype. It supports the T cell growth and survival. It reduces the corticosteroid sensitivity and prevents the T cell apoptosis. So that is how it helps maintaining the allergic response. At the level of macrophages, it induces an anti-inflammatory response, inhibits the Th1 inflammatory mediators, cytokines like IL-1, 6, 12, and TNF-alpha. However, it stimulates the interleukin 10 as well as interleukin 1 receptor production. Interleukin 4 works at the endothelium where the VCAM expression is increased, which enhances the adhesions of all the cells or like T cells, eosinophil, basophils, and monocytes on endothelium, but it does not promote adhesion of neutrophil on the endothelium. So that is how it facilitates allergic inflammation. At the level of mast cell, it increases the receptors for IgE as well as leukotriene synthetases, promotes leukotrienes, which is a very important mediator of inflammation, and it contributes to mucus hypersecretion, which happens especially in asthma. This interleukin 4 works by the signaling happens with the help of receptors, which eventually will activate the STAT6 signaling pathway in the cell. Now, there are two types of receptor. One is the interleukin 4 receptor, which are the heterodimers, and they bind only to interleukin 4, and they are present mainly on the macrophages. That means these macrophages will be stimulated only by interleukin 4. But the other type of receptor is interleukin type 2 receptor, which binds both to 4 and 13, and it is widely distributed in different kind of cells. Then there is the decoy receptors as well. There is a shared receptor that explains the 4 and 13 overlap in the pathways of inflammation. Let's talk about interleukin 13 now. Interleukin 13 is structurally significantly similar to interleukin 4, and there are overlapping functions. It is definitely one of the key mediators of asthma. They are identified in allergic tissues, that is skin, lung, and nasal mucosa. It is involved in chronic inflammation and remodeling. It is also produced by multiple cells like Th2, mast cell, eosinophils, and interleukin 2 cells, not produced by the basophils, and it is a major non-T cell source. The receptors, we talked about them. Apart from the type 1 and type 2 receptor, there is also a decoy receptor. Why do we need to understand about decoy receptors? Because while molecular targeting, we are looking at the antibodies which work on receptors as well. So if it is not a functional receptor, which is just a receptor not involved in inflammatory pathway, it will not work. So knowledge of receptor is equally important. Interleukin 13 function in allergy is well documented. It induces VCAM expression on the endothelial cells, promoting this vascular leak, edema. It also works on the goblet cell hyperplasia on the respiratory epithelium, which leads to excess mucus secretion. It works at the level of the smooth muscles, causing proliferation as well as contraction. It works at different cells like mast cell, macrophage, beta cells to promote the IgE production. It contributes to airway hyperresponsiveness. Between the 4 and 13, 4 is essentially a local uh, cytokine which has a synapse restricted activity and it promotes IgE switch. However, 13 is a systemic hormone like action and it is definitely not produced locally. There are multiple targeting molecules being produced, which will be talked by my successive speakers. Let's come to 9. Interleukin 9 is produced by the Th9, also produced by certain other cells. Th9 leads to interleukin 9 high and IL-4 low profile kind of asthma. The relevance is found in asthmatic patients and they are expressed in higher in asthmatic lungs. Again, effects on the multiple cells like mast cells, eosinophil beta cells, and airway epithelium. In the mast cells, they were initially described interleukin as a mast cell growth factor. It expresses the receptor expression. It promotes the cytokine releases from the mast cells. At the level of eosinophils, interleukin 9 increases the interleukin 5 receptor expression. Interleukin 5 and eosinophils are closely related because it leads to eosinophilic expressions. It synergizes with 4 and enhances interleukin 5 production, which in turn will lead to maturation of eosinophils. At the levels of B cells, it works with interleukin 4 to increase the IgE production as well as the memory cells. At the level of the epithelium, all the chemokines are expressed. We saw in the earlier slide that these chemokines were very important, the allergic cascade. It also produces the goblet cell hyperplasia. Interleukin 9 works by the interleukin 9 alpha receptors, which in turn stimulates the JAK pathway and leads to the statin, further targeting, further inflammatory cascade is initiated using the STAT1 and the STAT3 pathways. It contributes significantly to the airway remodeling. Coming to the next cytokine, which is interleukin 5. Interleukin 5 is a key mediator for eosinophilic asthma. It is secreted by the Th2 lymphocytes predominantly. However, it can also be secreted in some amount by other cells. Interleukin is a very important biological factor for the growth of eosinophil. There is eosinophil is produced and matured at the level of the bone marrow by interleukin 5. Its activation and migration is initiated by the eosinophils by interleukin 5, and eosinophil survival recruitment to the local tissue is also facilitated by interleukin 5. So it promotes its activation, survival, recruitment in the airway during the allergic pathway. Interleukin 5 also has a crosstalk with mast cells and they make an effective allergic effector unit. One initiates the other and there is a cascade of release of multiple mediators. Interleukin 5 mediated eosinophilia is responsive to steroid. However, if the levels are very high, interleukins are very high, and the eosinophilia becomes very high, this becomes the steroid resistant asthma. And this is also severe T2 high asthma. Interleukin 5 is a pivotal target for biologicals in such situations. Interleukin also works through a receptor. This is interleukin 5 alpha receptors, which again initiates the JAK pathway, and the STATs pathway is further initiated, which is it leads to the inflammation. Eosinophil depletion for interleukin 5 can be done by an antibody which is targeted against the interleukin 5. So if the antibody interleukin 5 is bound, it does not attach to the eosinophil and further reactivity doesn't occur. At the same time, there are antibodies which bind to the interleukin 5 receptors. So it prevents the attachment of the it prevents the attachment of interleukin 5 onto the eosinophils, and this leads to the apoptosis, the cell death. So what happens is anti-interleukin 5 antibody binds to the interleukin receptor and it depletes the eosinophil by antibody-dependent cell-mediated toxicity. So it reduces the eosinophilia at the same time. Then we come to the last of our targets, that is TSLP, thymic stromal lipoprotein, one of the very important upstream cytokine. It is produced by mast cells, epithelial cells, and keratinocytes. TSLP acts acts on the immature dendritic cells to mature and release CCL17. This CCL17 attracts Th2 cells via CCR4, and later on the other inflammatory mediators, the activation of Th2 cells releasing 4, 13 and 5, which are further acting on the B lymphocytes as well as the eosinophils can be seen. TSLP helps stimulate the Th2 cells. Th2 cells eventually will lead to the eosinophilic inflammation. Now, this is my last slide. If you look at the patterns of potential biomarkers in allergic disease, this is a paper published. So what they did was they looked at the biomarkers in different diseases. Diseases like atopic dermatitis in urticaria, sinusitis, asthma, esophagitis, as well as the food allergy. Now, if you see, all the biomarkers are color coded. Epithelial cells are shown in yellow, Th2 cells are shown in blue, Th17s are shown in green, and the cytokines in orange. And if you look at the color palette here, all the colors are present in all the slides. What does this mean? This simply means that cytokine expression is overlapping in different diseases. Cytokines may have their origin from several diseased organs, and one cytokine cannot be taken as a biomarker for one particular disease. They are not specific for a disease, they are not specific for a system, and they cannot be taken as a response markers for the correction of the disease process. Depending upon the inflammation, different biologicals can be used, which is going to be talked about by successive speakers. Thank you so much.
Thank you, Dr. Shalini, for initiating this very important seminar, and which will go on for the next 2 more days also. So far there are no chat. Very nice presentation, very basic thing you all given very nicely. I think we will move on, and you will be there, no, till the end of the
Yes, I'm going to
session.
be here.
Yeah,
Yeah.
yeah, yeah. So we can
There's so much to
move on to
learn.
the yeah, yeah. We are having an excellent speaker and very well knowledgeable and experienced people. And one pediatrician is over. It's a turn of one. We cannot call Dr. Karthik Nagaraj, who is budding pulmonologist. Sir. He is already developed into a big stage here. He is DM in pulmonology. He he must have inherited some things of allergy from Major Nagaraju sir, from we all have, many of us have learned, and he is heading one of the major allergy center in Tamil Nadu, one of the major thing in allergy in India, which everything they do, and he has got immense knowledge. He has done a fellowship from the Major Nagaraju sir, and also has a fellowship in intensive care. So he is a well experienced now. And he will be speaking on approved biological and allergic condition, global and Indian scenario. Welcome, Dr. Karthik. You can
Thank you, sir.
proceed. Yeah, you can finish in 25 minutes. Yeah,
Yes.
yeah, yeah.
I hope my slide is visible, sir.
Yeah, it's come. Make
Okay,
a
great. So thank you so much, sir, for the kind
make a
introduction.
make a full.
This is now in full screen. Is it simple? How about now?
Yeah, it's not come full. Go to slideshow and make it a full screen. Yeah,
Windows.
yeah, from beginning. Yeah.
Is that changing still? No.
No, it didn't click, I think, from beginning.
Okay. I think there's something's
Yeah.
going on.
Karthik, are you working on Mac?
Windows, sir. Windows.
Not Mac?
No, sir. It's on Windows. I have it. I got it. Is that now visible? Is it visible now, sir? Hello. Is it now visible, sir?
No, it was visible. Bring it
Oh,
back.
okay. Oh, okay. Sorry.
Bring it back. Share it again.
Now visible, sir.
Yes. Go ahead.
So thank you so much
Yeah.
for the introduction, and thank you, Neeraj sir, for the invite and for the amazing opportunity and the topic also of utmost importance for the art. I thank Dr. Shalini ma'am also for the nice segue for the base that she has laid, and so that we can discuss about what are the targets that we can use for our identified therapeutic markers. So we know that world allergic diseases are increasing worldwide, with nearly 10 to 30% cases increasing with prevalence in asthma or allergic rhinitis. The prevalence of atopic dermatitis is also increasing with nearly 4% of children. And also the scenario is also rising for conditions like chronic rhinosinusitis with nasal polyps and also in spontaneous urticaria. So why do we need biologicals in addition to our traditional therapies? The problem is there are so many medications available on pharmacotherapeutic aspect which target the receptors on there for they have specific receptors for which they do have a targeted treatment, but still they do not suppress or prevent long-term effects. They suppress the inflammation for the temporary effect, and as long as the pharmacological effect or half-life is present, the effect lasts that long, and then further there is no inability to use in conditions like severe or uncontrolled conditions like asthma, or there is no long-term effects with systemic adverse effects of using your systemic corticosteroids. And even in therapies like allergen immunotherapy, which is known to be a disease-modifying therapy, these are not yet recommended in severe or uncontrolled conditions like asthma. So we need certain biologicals which target certain specific components, which can be cytokines or immune cells or signaling pathways. So biological agents are nothing but products produced from origins from a natural source, which are constructed or produced using bioengineering or biotechnology. And these are usually of some antibodies or vaccines or some cell therapies. Unless told otherwise, a biological agent is almost always a monoclonal antibody. And now we have newer technologies which have been found to have improved the safety, and also new biomarkers are now available for the same condition or for different conditions, which increases the efficacy of using our monoclonal antibodies. So biological agent essentially is a targeted treatment, like how we said missile strike, surgical strike done to the particular target that you look at, like how Deepak Salwar sir always says that it's almost like a surgical strike. So to quote him, and then to say that this biological agent is used to reduce your dependence or need for corticosteroid agents, reduce the systemic reactions, the medication adverse effects, and also to improve quality of life while managing the severe forms of allergic diseases for which there are very few options available. So monoclonal antibodies are your essential biological agents which are belonging to the immunoglobulin G isotypes. A potential target is chosen, especially in allergic diseases. We choose a T2 inflammation target, which can vary from Th2 cells to IgE, mast cell, basophils, eosinophils, the cytokines that Madam has already beautifully explained, and the alarmins like TSLP are also some of the targets. So depending on the source of your monoclonal antibody, they have the suffix like humanized forms are Zumabs and human forms are humans. These are designed to interfere with specific immunological targets, which are administered either subcutaneously or intravenously, and they have long half-lives. So therefore, the dosing intervals are somewhere between 2 weekly to either 8 weekly. So Madam has already explained that we have different targets for different conditions. Like for an IgE, we have omalizumab. For an anti-IL-5, we have mepolizumab. For an anti-IL-5 receptor, we have benralizumab. For dupilumab, targets the interleukin-4 receptor alpha, and we have tezepelumab, which targets the thymic stromal lymphopoietin protein. Similarly, we have another model for the atopic dermatitis. The interesting thing about atopic dermatitis is it has a different reactions in different for different phases of the reaction. So for non-lesional atopic dermatitis, is predominantly alarmin mediated, and then the acute phase of atopic dermatitis is usually interleukin 4, 5, or IgE mediated, and for the lichenified or chronic stage of atopic dermatitis, usually Th17 and Th22 mediated. So now we begin with discussing about the first biological agent that was produced in the market, which is omalizumab, which is commercially available as a recombinant humanized monoclonal antibody belonging to the IgG1 category. This IgG1 goes and binds to the IgE antibody. So this is an anti-IgE antibody prepared using immunoglobulin G1. This is first approved for allergic diseases, and this has been used as subcutaneous administration. So what happens is the anti-IgE or omalizumab, the molecule, goes and binds to the CE3 domain of the IgE molecule, and this is responsible for binding with both the circulating forms of IgE and sometimes, in rare conditions, even the bound form of IgE is also attached to by the omalizumab. So the mechanism is, after binding to the C epsilon 3 receptor, it reduces or it binds to the free IgE. Therefore, it reduces the circulating IgE levels. It also reduces the cell-bound IgE. Therefore, the mast cells and the basophils, which are filled with IgE, are now down-regulated because they are not stimulated. And it also reduces the high affinity IgE receptors, like even the specific IgE in addition to total IgE. Therefore, they reduces the allergen binding to each specific IgE, and therefore it reduces the onset of immediate hypersensitivity reactions due to mediator release, and subsequently, because of downregulation and certain other changes, it also reduces the delayed reactions of your anaphylactic or IgE mediated responses. So across allergic diseases, omalizumab is approved for allergic asthma, where it has been found to reduce exacerbations. It reduces the inhaled corticosteroid requirements. It also improves control in moderate to severe IgE-mediated asthma. And especially, there is a paper which has been shown that in addition of omalizumab to allergen immunotherapy improves the tolerance or ability to add in patients who are on allergen immunotherapy also. So, because the IgE molecule is co-represented or common factor in several allergic conditions, omalizumab was proposed as a possible therapeutic option for several allergic conditions, including your chronic urticaria, where because of its ability to bind to your mast cells and basophils, it reduces the mast cell and basophil activation, improves especially in the antihistamine refractory cases, where now it's recommended as a second-line treatment in for CSU in the West. And this is especially useful in patients who have this auto FC antibodies directed against their FC epsilon receptor 1 to the anti-IgE receptor. Subsequently, also in rhinosinusitis, where it has been shown to reduce the polyp burden and nasal congestion, particularly in patients who also have a comorbid asthma. This is also seen among patients who have this aspirin sensitivity, or your NSAID exacerbated respiratory disease patients are also particularly benefited by adding omalizumab to therapy. One interesting finding was similar to how it binds to specific IgE. It was postulated to be useful even for IgE-mediated food allergies, particularly single food allergies or even multiple food allergies, where upon completion of IgE therapy, they were able to successfully tolerate the particular food. However, there was no effect on desensitization. Unfortunately, in atopic dermatitis, IgE omalizumab studies did not show any changes, so it is not recommended. So one of the findings that I wanted to put up was that in March 2024, there was this outreach paper that came out and showed that omalizumab was tried in patients who were allergic to IgE-mediated allergies to food, at least 2 foods or more than 2 foods, and they found that addition of omalizumab, the children were able to tolerate almost all the foods. Subsequently, if not to just 1 food, all the 3 foods they were able to use, and therefore it was FDA approved for IgE-mediated food allergies, particularly the severe forms, for more than 1 year of age. they did successfully reach their threshold doses, which are considered safe for consumption, but it was not desensitization alone. So for asthma, your omalizumab is useful from ages 6 years and above who have a perennial aeroallergen sensitization, where the total IgE and body weight has to be within the range. So because it is based off on the body weight and IgE mediated doses, the patient should also have a frequent exacerbations, and also there is a proven benefit with patients with allergen immunotherapy. The severe forms of chronic urticaria, where the UAS7 score more than 16 in children more than 12 years of age, where a cutoff of IgE more than 56 is found to be best responders to chronic spontaneous urticaria. Also, in patients, adult patients with chronic rhinosinusitis with nasal polyps, who are poor responders to intranasal steroids, and in food allergies, just like how we discussed right now. So this is a paper where they found in a meta-analysis that addition of omalizumab to severe pediatric asthma was also useful, and a subgroup of those patients were on allergen immunotherapy, and this they found that there was an increase in the percentage of patients who were able to reach the maintenance dose even among severe pediatric asthma patients. So that was about omalizumab, and we will talk about the next biggest target and the most commonly used among practitioners is mepolizumab, which targets the eosinophilic inflammation. So this is a humanized IgG1 monoclonal antibody targeting IL-5. This prevents the binding of an IL-5 with the IL-5 receptor on the eosinophils and basophils, and therefore it affects the growth, survival, and proliferation of the eosinophils, and therefore the eosinophil number goes down over time. It reduces the blood and tissue eosinophils, thereby decreasing the airway remodeling and exacerbations because of Charcot-Leyden crystals, and your number of extracellular traps are also reduced. And this is being found to be useful in asthma, where they notice that it reduces the circulating eosinophils, sputum eosinophils, and also exacerbation rates with an improvement in FEV1 over time. So similar to mepolizumab, reslizumab was also released, which is also a similar anti-IL-5, but reslizumab is an IV medication, mepolizumab is an subcutaneous medication. So this is being used in recommended in age more than 6 years of age for particularly severe asthma patients who have a eosinophilic phenotype of more than 150 cells per microliter. Because of its effect on eosinophils, it is useful in patients with hypereosinophilic or eosinophil-related conditions like hypereosinophilia, more than 12 years of age, or EGPA also. However, you have to note that the higher dose is required for treatment in these conditions. An interesting paper came out recently where they found that mepolizumab was also recommended in patients who were inadequately controlled COPD with an eosinophilic phenotype, were also candidates who benefited with mepolizumab. So this is officially recommended and even FDA approved for COPD patients in the US. So some of the predictors of response to mepolizumab would be a high baseline eosinophil count, younger ages, less than 65, non-obese patients who have a coexisting rhinosinusitis with polyps, and sputum or nasal eosinophilia. A similar target, but in addition to IL-5, there was also a competition as to look at how can we further reduce or further have an effect on eosinophils. So anti-IL-5 receptor was the target here, and therefore benralizumab monoclonal antibody came into the picture. So this is an afucosylated molecule, which is IgG1 monoclonal antibody, again a humanized antibody, and it targets the interleukin 5 receptor alpha. By preventing the interleukin 5 binding with the interleukin 5 receptor alpha, it also acts as an antibody-dependent cytotoxic cell-mediated cytotoxicity, or ADCC, whereby it also reacts with the Fc gamma receptor on your NK T cells, and therefore it also leads to eosinophil apoptosis. So in addition to just downregulating the interleukin 5 receptor and reduction in eosinophil count, this is responsible for rapid and sustained eosinophil depletion, and therefore it has been useful in reducing the blood and tissue eosinophilia. So this is approved based on several trials. The details I will not go into, which will be handled by further speakers. It has been approved in severe eosinophilic asthma, where patients, it has been found to reduce exacerbations and the oral corticosteroid use. The fastest reduction in oral corticosteroid use is also noted with benralizumab. It improves lung function and has also been found to be improving the symptom control. So age more than 6 years with severe asthma and eosinophil more than 300 are the typical recommended usages for in asthma. However, its use in rhinosinusitis and COPD is currently under evaluation. And for EGPA also, more than 18 years of age, who have a relapsing or a refractory EGPA, the similar doses required for downregulating and depleting the eosinophils. Some of the predictors of response would be eosinophil more than 300 with the frequent exacerbations more than 2 times a year, coexisting nasal polyps, late onset asthma, who have an oral corticosteroid dependent asthma, and also FEV1 less than 65% predicted are some of the better responders to benralizumab. So coming to this, we discussed that in addition to interleukin 5, eosinophil mediated inflammation, interleukin 4 was also key T2 driver of inflammation. So one of the molecules targeting the blockage of interleukin 4 and interleukin 13 signaling, not interleukin 14 signaling, interleukin 13 signaling, is dupilumab. So this is the only fully human IgG4 monoclonal antibody being against interleukin 4 receptor alpha, and madam has already explained that receptor alpha is responsible for binding for both interleukin 4 and for interleukin 13, and therefore it is able to block both the activities of interleukin 4 and interleukin 13. So because of this effect, it is now able to reduce IgE production, because IgE production is mediated by interleukin 4, which stimulates the plasma cells to secrete IgE. Eosinophil production, mucus secretion, and barrier dysfunction all are taken care of by dupilumab. Therefore, the range of approval is much wider, starting from atopic dermatitis, where interleukin 13 mediated your barrier dysfunction or filaggrin dysfunction is better taken care of with dupilumab. That was the first indication. Subsequently, in asthma with type 2 inflammation, rhinosinusitis, and interesting information is that about eosinophilic esophagitis is also an indication for use with the dupilumab and also with chronic spontaneous urticaria. So this is a big table, but what we will concentrate on is that in atopic dermatitis, it is useful from ages as low as 6 months and above, who have a moderate to severe atopic dermatitis score of more than, or eczema activity severity index score of more than 21, who are not responding to topical therapies. The treatment is usually weekly, 2 weekly, or 4 weekly therapies, depending on the weight and the age. In asthma, it is recommended in more than 6 years, who are predominantly eosinophil type, who have a oral corticosteroid dependence, and in chronic urticaria and in chronic rhinosinusitis for more than 12 years of age, wherein in rhinosinusitis it is a fixed dose, every 2 weekly dose is recommended. COPD also has come up with a new paper where they found that in inadequately controlled COPD, who have a eosinophilic phenotype, are also good candidates for COPD, for dupilumab, sorry. And for eosinophilic esophagitis, age more than 1 year, a higher dose of dupilumab is required. Almost weekly administration is required for therapy, and this has also been found to be useful in severe eosinophilic esophagitis resistant to your first line and second line therapy is now one of the commonest recommendations in pediatric age. Patients who have a higher blood eosinophils and a higher pheno are strongly predictive, especially when if they belong to the asthma, and they are better responders to dupilumab. The final molecule that I will be touching upon is the tezepelumab, which is the broad spectrum antibiotic. This is because it is an upstream phenotype independent action, because it acts at the level of the epithelium or alarmin level. So the first molecule that gets secreted in response to virus, cigarette or pollutant exposure, bacterial allergen, or physical injury is your alarmins. One of the important alarmin is your TSLP, and by blocking this, it inhibits not only the T2 mediated but also the T1 mediated TH17 or non-T2 mediated inflammations are also taken care of. And this is a first-in-class medication, and which is useful in not only in TH1 but also in TH2 inflammation also. So currently it is approved only for asthma age more than 12 years and above, for severe uncontrolled asthma at a fixed dose. The clinical effects based on the Navigator trial is that these asthma patients are known to have reduced exacerbations across the eosinophil levels, across low eosinophils to high eosinophils, all respond equally to tezepelumab, improved lung function and asthma control, and there is low levels, or steroid-dependent patients also have the same efficacy as those who are high eosinophil counts. Patients who had the highest exacerbations in the previous 12 years and the pre-bronchodilator FEV1 were better predictors of response to tezepelumab than other things. So you just need a clinical predictor tool, not a biomarker, to predict response to tezepelumab. So based on all this information, US FDA and European Medical Agency approved the following molecules for the different types of your cytokines targeted therapies. So we know in IgE, we have discussed about omalizumab. Ligelizumab is another subcutaneous anti-IgE molecule, which is not yet approved, but it is looked at in the West right now. So it is approved in allergic asthma, chronic spontaneous urticaria, rhinosinusitis, and in food allergy also. Interleukin 5 blockers like mepolizumab and reslizumab are especially approved for eosinophilic asthma and for EGPA and hypereosinophilic syndromes. Your interleukin 5 receptor and blockers like benralizumab is especially useful in your EGPA and severe eosinophilic asthma. Interleukin 4 blockers like dupilumab has got the widest range of recommendations, including eosinophilic esophagitis and atopic dermatitis, starting at more than 6 months of age. Tezepelumab is especially recommended now only for severe asthma. However, we anticipate more uses because of the upstream effect. And interleukin 13, again, tralokinumab is not yet approved. It is in the West for and lebrikizumab for atopic dermatitis. So disease-wise also, there are only few maps which are recommended. If you can see here, dupilumab is the one that is able to use across spectrum, even across chronic spontaneous urticaria. Mepolizumab is recommended in chronic rhinosinusitis and in asthma, but and only in US. So this is, and for what is the situation in India? So in India, we have approvals for omalizumab from 2007 onwards for allergic asthma, chronic rhinosinusitis, and for chronic spontaneous urticaria. And for mepolizumab, we have approval for eosinophilic asthma, EGPA, and hypereosinophilic syndrome. Benralizumab for EGPA and for severe eosinophilic asthma. Dupilumab is approved currently only for moderate to severe atopic dermatitis. Several studies are ongoing in asthma right now. And tezepelumab is not yet approved or available in India. So we know that with better understanding, we have allergic diseases are there right now, and it is continually improving. We are able to better endotype and better choose targeted therapies. In India, we have certain therapies which are now available for use, and we know that biologicals significantly improve outcomes in allergic diseases, and we have to use the right test for the right patient and identify the ones who will respond better to the right biological agent. And we have to use appropriate biomarkers. Thank you for the opportunity. I hope this is good.
Thank you, Dr. Karthik. I hope you also will stay for till the end. But we have a few questions for you from Dr. Neeraj. Can two different biological targeting different molecule be be started simultaneously?
So that's a interesting question because first of all, it's a very bumper question. The thought process here is that you can use two different biological agents for two different, but not simultaneously. It is added sequentially. So the one studies where they've used this, where can we switch from one biological agent to another biological agent, has been looked at in several studies. They did look at that you can switch from an anti-IgE to an anti-IL-5 therapy in patients with chronic rhinosinusitis with nasal polyps, or patients who have previously poor responders to anti-IL-5 were then switched over to dupilumab, anti-IL-4, anti-IL-13, but not simultaneously from what I know.
Book can be continued or you can change to other one.
So you can switch provided you identify the right patient, and if they are not poor responders, you identify that they belong to a category where you can use them for, let's say, dupilumab is an option available for somebody who is on treatment for chronic rhinosinusitis with mepolizumab, and they did not improve. You can use provided they have high eosinophils in their nasal count. You can switch, but simultaneous use, I'm not sure. Maybe Deepak sir can throw light on that.
Dr. Talwar sir, you want to add anything here?
I think it's a very, very, very controversial and a contentious topic to discuss where patients are not. When I'm going to talk about the cost factor, adding two drugs together would be like more of a bomb to the patient. But yes, there are anecdotal reports where they have tried both, especially in the overlap group where both the IgE as well as eosinophils are high and are the drivers of the inflammation in an individual patient. We showed the data that nearly 30% of patients do belong to overlap group in India. I think the issue is that what Karthik said, you start with one, and if it doesn't do well, you go to the other one. But in some situations, you get stuck where, you have started one and the response is about 50 to 60%. And at that point of time, losing that and starting the next one is a little jittery thing. We do it almost every time. But today, if the cost is not the factor, I would say why not actually. So if you can, as Karthik said, you can actually target in the missiles two, three things together, you can do it. So why not here? We can combine two missiles together to individual patients who are really being troubled due to the overlapping phenotype, or rather what we call as a phenoendotype, where it is T2 high inflammation, but T2 high inflammation is not only because of IgE, but also because of eosinophils.
Yeah, one more question. Dr. Karthik was there. Should one monitor total Ig or eosinophil after each dose of biological or after completion of recommended course? Or there is no
So,
need also?
yeah, so there is now no recommendation to look at monitoring Ig levels or eosinophil levels, but then in the situation where you are suspecting that response is insufficient and you want to look at changes, but yeah, so this is again the gray zone, right? So previously it was recommended that you should follow up your Ig levels and look at response versus not response, but then now we don't tend to check Ig levels as a monitoring tool for patients. However, prior to stopping therapy, is again some discussion that we do have. We look at Ig or eosinophil levels. We do check prior to stopping to look at whether their levels have sufficiently come down over time or not. So again, somebody like so might be able to throw better light on it because of his vast experience.
Thank you, Dr. Karthik. I think that was an excellent session. There are
So
other one or two
can I add
questions.
one point to that last question?
Yeah, yeah.
So
Yes, ma'am.
whenever you give biologicals for any IG-mediated diseases, the most of the time the prognostic factor is the symptom relief which the patient is getting. So we have various type of score. Like for the polyps, we have some score. If the patient is better, that itself is proven that it is good. And for IG, once you have given the omalizumab, actually because it binds with the free circulating IG, if you do a blood test, the IG will come as double or triple. That is mentioned in the literature also. So what happens if we give the injection, many times the patient thinking that I have got this injection, my IG will come down. They will do the IG test and the number will be double or triple, and then they will be questioning you. So one has to be aware whether we ask the patient to do IG or not. Usually we don't ask it. That is what we do. I think Dr. Talwar sir can give more insight on this, but we have to understand that we should not be doing IG for at least a year after the injection.
Yeah, thank you. There are a lot of other questions and they're overlapping. There are one or two questions I think Dr. Other in next one or two talk also it will be covered and then we can consider. I request Dr. Karthik to please be with us till the end. Your expertise will be required. Yeah. And it's now over to you, Dr. Sunita, who doesn't need any introduction. She has been labeled as a allergy queen and has been honored by so many peoples. And she's for those of you who do not know her, she is an basically ENT surgeon, and she is a flag bearer of allergy in the otorhinolaryngology association in India and among the ENT. And there's a lot of work, so much of work that she has done, and with the publications, everything and all. So it's over to you, Sunita, to give your wisdom on this topic on chronic rhinosinusitis with nasal polyposis and allergy, endotyping, and role of biological.
Yeah.
Yeah.
Hi, good
Okay.
evening, everyone. Is my slide visible?
Yeah.
Yeah,
Thank you.
okay. So at the outset, thank you, IAP and Dr. Neeraj for giving this opportunity to me about talking on CRS with nasal polyps and biologicals. And we will be discussing mostly about nose and the allergy and the endotyping and so on. And I thanks all my previous speaker who have set the ball rolling regarding the biological use. So coming to chronic rhinosinusitis, basically CRS is a presence of two or more symptoms which will be usually a nasal blockage or obstruction with or without facial pain and pressure or loss of smell. And this should be for more than 12 weeks. And most of the time, it will be seen that whenever you have CRS, there will be an overlap of allergic rhinitis. Most of the patient will start with the symptom of allergic rhinitis, that is sneezing, itching, running nose, blocked nose, and so on. So please always ask a history of allergic rhinitis along with the CRS history also. The pathogenesis of CRS is basically a epithelial barrier dysfunction, and you will see in most of the allergies, the barrier dysfunction comes first, which causes lot of inflammation and then infection with lot of bacteria like staph aureus. This is true for atopic dermatitis, for some eczema, and so on. So in CRS with nasal polyps, the nose epithelium break is there, which causes lot of inflammation leading to CRS. Now to add on this thing, there could be some genetic factor. A patient can have some immunodeficiency, cystic fibrosis, or ciliary dyskinesia. To add on to that, there could be some immune deficiency, environmental factors like occupation, smoking, pollution, which is in vogue nowadays, and also some of the infection by staph aureus, viruses, and most of them will cause lot of dysbiosis, causing a recurrent inflammation again and again and giving rise to CRS and so on. So the EPOS guidelines of 2020 says that the host factor, environment factor, and the barrier dysfunction will decide on the types of endotype of the patient, and eventually how the way the tissue remodels, which actually give the phenotype, which is a natural history or a clinical presentation of the patient. Most of the time, a patient with allergic rhinitis can land up into CRS with nasal polyps, and also most of the time, these patients can have other IG-mediated diseases like asthma, which comes into the preview of a united airway disease, that is one airway, one disease, and other IG mediated disease also like food allergy, drug allergy, and so on. So coming to the phenotypes of CRS, it is divided into CRS with nasal polyp and the other is without nasal polyp. Most of the time we see CRS with nasal polyp a lot, and this is actually a eosinophilic mucin rhinosinusitis. Allergic fungal rhinosinusitis or AFRS is also included in this, and we have a small portion of patient who will come with the aspirin exacerbated respiratory diseases or the Samter's triad also. Some of the patient can have CRS without nasal polyps, and these are because of the innate immune defects, hypogammaglobulinemia, cystic fibrosis, or PCD type of diseases. But the major chunk which we see nowadays are the CRS with nasal polyps. Now coming to the endotypes of CRS, most of the time the endotypes are divided into three, which is type 1, type 2, and type 3. If we see correlate the endotypes and the phenotypes, the type 1 is basically the lower bottom of the picture, which will have more of a neutrophilic variety, and here TH117 and TH22 cells are involved. But what we see most commonly is a type 2 inflammation, which the patient presents with allergic rhinitis, local rhinitis, or CRS with nasal polyp. Here, TH2 cells are involved, especially the eosinophils, and the markers which we get in TH2 types are the IL4, IL5, and IL13. In type 1, we have the TH1 cell, which gives rise to the markers of TNF alpha and the interferon types. Now, also we have a third variety called as a type 3, which involves the interleukin 17 and 22. So clinically, if we see the TH2 varieties, which compromises of CRS with nasal polyp, the cytokines which are involved are 4, 5, and 13. They act on the basophils and the eosinophilic cells, and that's why the eosinophils are very high at this time. Many of the time, a parasitic infection can also give rise to this type of inflammation, and that's why most of the time the IgE will be raised in these patients. And these patients can come with allergic rhinitis, CRS with nasal polyp, asthma, loss of smell, and so on. And the very fact that they are Th2 positive, chances that they will respond to corticosteroids, immunotherapy, or biologicals is very high. This is a very typical picture of a patient of CRS with nasal polyp. The upper one is a normal nasal endoscopy and a CT scan, but the lower one shows a CRS with nasal polyp. And this patient also had a concomitant asthma. So central compartment atopic disease is a term given to patients who have the disease present only in the central compartment of the nose when we do a CT-PNS. And the reason for this is whenever a patient who has allergies, when he breathes the air, the allergen are in contact with the nose mucosa, and that's why all the haziness or the inflammation happens in the central compartment and not in the periphery, that is the sinuses. Hence, it is called as CCAD. This is a very typical picture of a diagnostic nasal endoscopy which is done for a patient. He is a case of recurrent nasal polyps. This is of the left side of the cavity. Here you can see the nasal septum. This is the inferior turbinate. These are the nasopharynx and the adenoids. This is the middle turbinate. And this on the right side, what we see is a maxillary sinus ostium. This patient was already operated and the left side is absolutely fine. But now coming to the right side, we can see there is recurrence of the polyp, and that's the suction. And what we are suctioning now is the mucin, and this is a very typical clinical feature of patient of allergic rhinitis or where we have a Th2 type of inflammatory marker. So this mucin contains lot of eosinophils. Many times you can take a nasal spray to see the eosinophils. And now once the suctioning is done, what you can see is the polyps, and this is a recurrent type of polyp in this patient. So this patient has this surgery done 3 times, and every time he was coming with the recurrence of the polyps. So when such a patient of CRS with nasal polyp comes to you, most of the patient will undergo a sinus surgery, which is the first line of treatment. And after proper post-operative care, still if the polyp persists or there is a recurrence, most of the time the doctor will be giving a short course of oral corticosteroid, which is actually the right thing to do. But in minority of the patients, many of the time there is contraindication for the surgery. The patient can have some other concomitant disease like asthma, which will be dependent on the corticosteroids. Or nowadays patient even says, I don't want a surgery. So in such cases, one can consider biologicals. When we give steroids, we don't want to have the side effect of steroids, though oral corticosteroids are the most anti-allergic and anti-inflammatory. But whenever oral corticosteroids are given, it causes lot of side effects, especially when it is given for a long term. And in India, it is a very cheap drug and it is easily available on the counter, and patients misuse it a lot. And most of the time, they will come with recurrent infections, myopathy, cataract, stomach ulcer, other complications, and so on. So it is always better you give them the options of biological. Now coming to one more phenotypes is a AFRS, which also comes into the variety of CRS with nasal polyp. And AFRS basically consists of eosinophilic mucin, non-invasive fungal hyphae, and a type 1 hypersensitivity to the fungi. And EPOS says that these type of patients can be classified into 2 types. If the patient is immune hypersensitivity, you get AFRS. If patient is immunocompetent, you get a fungal ball. But if the patient has immunosuppression, we get an invasive fungal rhinosinusitis. And this is decided once a surgery is done, you send the tissue for biopsy, and depending the invasiveness of the fungus, we do the classification. So coming to the type 2 inflammation in CRS with nasal polyp, my speakers before have highlighted it very well. But here in Th2 pathway, the main culprit are the interleukin 4, 5, and 13, which cause increase in the IgE level and leading to a lot of eosinophilia, and they have an effect on the cell recruitment, mucous response, and the remodeling. So the solution for such CRS with nasal polyp and the game changer are two. Initially, we thought the game changer is biological, but I think the allergy and immunotherapy also helps in this. We will see the real world data later on. Allergen immunotherapy is basically a disease modulating treatment which actually modulates the whole immunity from Th2 to Th1. And it is a very unique and unmatched model of precision medicine where the medicine is tailor made for the patient as per the skin prick test and second history correlation. And this is a best personalized medicine for the patient and gives the best result. Biologicals are products which are made from living organism and they contain one or their components. Karthik has very beautifully explained all the biologicals, but the biologicals which are approved for CRS with nasal polyps are omalizumab, dupilumab, benralizumab, mepolizumab, and so on. Coming to the indications, when you decide that, okay, we can give biologicals, so there are some criteria put forward by these EPOS 2020 guidelines. So in a patient of bilateral polyp who already had a endoscopic sinus surgery, we require 3 criteria before starting the biologicals. The first criteria is that you have to prove that it is a type 2 inflammation. How do we prove it? Very simple clinical test. When you send a histopathology of the nasal biopsy, you ask your pathologist to give you the tissue eosinophilia count per high power field. If it is more than 10, it is a type 2 inflammation. Or other indicators are a blood eosinophilia, that is you do a CBC. If it is more than 250 or a total Ig level of more than 100, itself signifies that this is a type 2 inflammatory pathway. Other criteria are the patient requires corticosteroids more than 2 courses per year, or he is on a long-term corticosteroid for more than 3 months. The quality of life is impaired. We have a SNOT 22 questionnaire, which if it is more than 40, that means the quality of life is poor. Anosmia or lack of smell is a very important history and a criteria to start biologicals. And if the patient has any other Ig mediated disease like asthma and he requires corticosteroid very frequently, then they can be also given biologicals. So if a patient has 3 criteria in someone who had the surgery, 3 criteria are required. But if the patient says, I don't want surgery and it's a virgin nose, then 4 of these criteria should be fulfilled so as to start the biologicals. So the best biologicals are dupilumab, mepolizumab, and omalizumab. Karthik has already included everything. So dupilumab is more for IL-4 and 13. I am not again repeating it. Omalizumab is a anti-IgE which binds to the free circulating receptor. This is a video of how the IgE works. You can see these are the free floating IgE which are present in the body and on the mast cells. Whenever a allergen enters into the body, it attaches to this the IgE on the mast cells and causes degranulation of the cells, causing release of histamine and other mediators. When you give omalizumab, the omalizumab will bind with the free circulating IgE, and now they are not available for any reaction. And since this goes on for a long time, eventually the IgE production by the body will be decreased. And even though there is an allergen, since the Ig is not available for any reaction, the patient does not react to it. So most of the time we have given omalizumab in our practice. So how do we decide what amount of dose to be given? Here you need 2 things, the weight of the patient and the pre-treatment Ig level. Depending on that, you can decide the dose of the biologicals. Now, looking at the how do we assess whether patient is becoming better or not? So most of the time, the prognosis is decided based on the symptom of the patient. So in CRS with nasal polyps, we have 5 criteria. We see whether the nasal polyp size has reduced, whether the need for systemic corticosteroid has decreased, what is the quality of life, whether smell has increased or not, and what is the impact on other comorbidities. Now, if the response is good, we continue the treatment after 16 weeks from till 1 year of age. But if there is no response in 16 weeks, we then discontinue the treatment. This is a best prototype study for omalizumab in nasal polyp done by Dr. Philip Gaviot, and he did this study for 52 weeks for the patients, and the scores which he monitored was the nasal polyp score, nasal congestion score, SNOT 22, and the total nasal symptom score. And they realized that the results of omalizumab use in this nasal polyp decreased the nasal polyp a lot. So in India now, dupilumab was supposed to be available. We still don't have it practically. So omalizumab, if you can see in what conditions we can use, omalizumab works very good in allergic asthma, urticaria, and CRS with nasal polyp, and also as an umbrella when you have to give allergy treatment along with immunotherapy and for other condition like food allergy and so on. My previous speakers have already covered this part, so I'm skipping it. So these are the new 4 Ps of precision medicine. Whenever you want to treat a patient, understand the participation of that patient, take a preference of the patient, whether the patient wants a surgery or the biological, and depending on the endotype, you decide on the treatment. This is a summary of the biological use. How do you select the patient, the criteria, the choice of biologicals, on what basis you will treat which biological, and how do you evaluate the treatment response at 16 weeks or 1 year. Now, looking at the future is very bright. Biologicals in CRS, we have new therapies coming in. We have, anti-IL-25, IL-33, and anti-TSLP. They are still not available in India, but very soon we expect them to be available. Also, we have some biologicals for CRS without nasal polyps, and they will be available soon. Maybe it will take 1 or 2 decades in India. But coming to some clinical aspects, so whenever you have a patient of allergic rhinitis and polyps, always take a detailed history, understand what are the allergens causing the problem. So please do a skin prick test or a blood testing. Most of these patients will have allergic asthma also, so always take a history of wheeze, do a spirometry, peak flow meter. For nasal polyps, do a nasal endoscopy. Always to understand peripheral eosinophilia, do a CBC, a serum Ig level. And if you have taken a polyp biopsy or done a surgery, go for nasal polyps or eosinophilic count. These are few cases where we encountered such patient with AR and CRS with nasal polyp, and you can see with treatment of allergen immunotherapy and biologicals, the polyp have regressed a lot within the first 4 months. This is one of the second case. One more case of AFRS, who he's a doctor himself, and he is doing so well on biologicals. But you have to understand, whenever a patient comes with, whether it is allergic rhinitis or CRS with the nasal polyp, we most of the time these patient will also have other symptoms and other allergies, which can be asthma, food allergy, drug allergy, and so on, and they come into the preview of multiple allergy syndrome. So please take a holistic view, understand what is the allergy, what type of endotype the patient is, and then you decide on the biologicals. Now we don't have the original biological omalizumab. We have biosimilars, and we have a very rich study of using biosimilar at our center of more than 1,200 patients for various IG condition, and the results are really promising. One study which I would like to highlight is when we were seeing all these patients, we were treating the nose allergic rhinitis with allergen immunotherapy. The polyps we were treating with omalizumab, and we eventually realized that as the nose symptoms were becoming better, the need for biologicals were decreasing. So with this, we presented our paper in the last year European conference, and this is the only paper in this world. We have discussed it with so many doctors internationally, where I could show 21 patients of allergic rhinitis with recurrent CRS with nasal polyp, and we realized that maybe the allergen immunotherapy does decrease the use of biologicals because it may be altering the inflammatory pathway. So to conclude, I feel that whether we give pharmacotherapy or biologicals or steroids to all of these allergic patients, all of them are temporary. Even the biological, the main limitation is they work till the time you're giving it. The time you stop it, the symptoms start occurring. So we don't know till what time we have to give them. So they are temporary. But I think allergen immunotherapy is like a turkey champion who just comes with one revolver, one bullet, and he has taken the bullseye shot. So maybe allergen immunotherapy can actually modify the whole disease for treatment. So if your patient has atopy, allergic rhinitis, and then CRS with nasal polyp, please, along with biologicals, consider giving him allergen immunotherapy also, which is a disease modulating treatment for these allergies. So my take home message will be CRS can severely impact the quality of life. CRS with nasal polyp and AFRS can be due to Th2 inflammatory response. To prove Th2 inflammation, please do simple 3-step CBC for eosinophilia, serum Ig level, a polyp histopathology, and please refer these patients to allergy specialist for diagnosis, immunotherapy, and biologicals. And please consider allergen immunotherapy as it is the only disease modulating treatment which changes the allergic milieu to a non-allergic one. With this, we have some fellowship course. If anyone is interested, please write to us. And I thank you for your patient listening. And I'm open to question and answer now.
Yeah, thanks, Dr. Sunita, for wonderful insight into this. Especially your so much of experience of using omalizumab and in chronic rhinosinusitis, rhinosinusitis is when, and you have nicely said that allergy and immunotherapy should be better option if you do it early. So that's okay. But even if it is already multiple time patients are going for surgeries and all and becoming chronic polyposis and all. So is it here even a immunotherapy will help?
Yeah, so I think it helps. That is what my last few slides were, because I feel somewhere the Th2 pathway starts with a symptoms of allergic rhinitis. And allergic rhinitis has a lot of other comorbidities. The sequelae which will happen. Asthma is one of it, and CRS with nasal polyp is one of it. And if you can prove that it is a Th2 pathway causing all these things, then yes, immunotherapy does work. And that is what we showed in the European conference of 21 patients. Now, most of them are only on immunotherapy and the need for biologicals have decreased. So we give it for 4 months and then we slowly decrease the duration. Like the injections are every month, then we do it in 1.5 months, then we do it for 2 months and we gradually decrease. But the polyps are not coming back. We do a nasal polyp score, we see the symptom score, and that is how we grade this patient and we take a call on continuing that.
Yeah, yeah. And to your patient, there were so many patients there, but they have many of them had asthma also.
Yeah, many of them had asthma. So the cases which I have showed, most of them had asthma. So whenever you give omalizumab, like my maximum, I have given omalizumab for eosinophil, like I refer to my pulmonologist friend. So you will see that the symptoms decreases, the need for the medications decreases, the ICS dose decreases, the need for oral corticosteroid decreases, and their asthma exacerbation or hospitalization also decreases. So this is a very good result. So whenever that's what I said, whenever we see a patient, we have to see the holistic view. What other IG diseases the patient is having. If it is an atopic dermatitis patient with AR, polyps and urticaria, then you can obviously go for dupilumab, but it is not available. Dr. Talwar sir will be talking more about asthma and the Indian scenario now. So I think we will be able to answer much more there.
You have used only omalizumab
I've used
and found a good. So if Dupili was there, you would have jumped on that. It's not available, so
Sir, but
so there's an
as sir
issue.
said in the last comment, cost is a
Yeah.
huge issue. Initially, we had the original omalizumab. Now we don't have that in Indian market. What we have is biosimilars. But we have done a study comparing the original product with the biosimilar. The biosimilars are also very effective. And we are very proud to present this data whenever we go internationally. And even the patients where insurance is not covered and they have to spend from their pocket, they're very willing to take those biosimilars because they come comparatively cheap and the results are good. So I think the biosimilars are an answer to this
Yeah,
problem.
we'll have a opinion from the lawyer sir also afterwards. And you must have used the maximum number of biologicals in ENT side, at least I feel. Dr.
Yes,
Talwar
yes.
is there for us, who must have used much more than overall scenario. Yeah? right from the beginning. One question is there, have your patient, any of them had a scimitar syndrome, aspirin sensitivity?
No, so I have still not seen even one in my practice. I have more than 4,000 patient database. So I have not come anyone with the Samtus triad. I don't know why. I don't know
Okay.
whether in
Yeah.
Western India it is not so common.
Yeah. So there was one question for you. What do you prefer for chronic rhinosinusitis nasal polyposis between Mapoli and Dupili? I think you use
I have used only
Omali
Omalis.
only.
Yeah,
Yeah.
because if the patient has suppose allergic, the eosinophilic
Yeah.
asthma and all, I always take a opinion of my pulmonologist colleague because I am a
Yeah.
ENT. So I always believe in team practice. If some there is skin issue, I speak to my dermat friend. I speak to my pulmonologist. And if mepolizumab have to be given for the asthma and all, I refer very happily refer it to them. Only it is when there are some other IG disease that I have to give omalizumab, I treat those patients.
Yeah. So there's one question about the role of Mapoli Dupili in acute fungal rhinosinusitis,
No, so
AFRS.
we have not used it. We have not used it. And I don't think there is much role in AFRs. So omalizumab does have a role, but I have not used it. Maybe if sir has used it, I don't know. Because they see a lot of ABPA also.
Okay, we will leave it to sir, and please wait for another half an hour. The excellent part of the session is coming now. So, for the climax of our thank you, Dr. Sunita, and
Thank you,
we
Danish.
have none other than Dr. Deepak Talwar, sir, who I think in India has one who must have started using this quite early, and one of the first person, and must have used this maximum. So we must be having the maximum experience. For those of you who do not know him, he's a director of pulmonary sleep and pulmonologist at Metro Center for Respiratory Disease in Noida, and he is the authority on this subject. And we are lucky to have you, sir. So please carry on, sir.
Thank you, Danish. And is the screen visible?
Yeah, full. Okay,
Full
full,
screen?
sir. Yeah, yes, sir. It's full.
Okay, great. Thank you very much. And I've been listening to this entire webinar with great interest. I'm very, very happy that allergy specialists too have embraced the biologicals very well. And wherever we are trying to, cut corners, it is primarily because of the cost. And maybe that's the reason why the topic given to me is cost monitoring and duration, because I think people want to know that how to navigate the cost of the therapy in these patients who are really deserving but cannot afford it. I think that's a major thing, and I'm sure that that must have been in the mind. So I think it's basically an allergy course in which you need to know how to actually navigate the cost and give the benefit to the patient, and of course decide on an optimal duration, and of course how to monitor. So I'm talking about biologicals cost. So we all have known, because Shalini very nicely started with the precision attacks of targeted medicine, targeted therapies, and I think she even took the name of absolutely, I think, stunning and very, very I think to be proud of being an Indian on an Operation Sandur, that we have targeted therapies which are actually now very easy to understand after all these terminologies have made their appearance in each and every home, or perhaps in every living room where these discussions are. Like you strike something, it goes there and it just neutralizes that and doesn't do any collateral damage. I think that's what the major thing is we are talking about, that we manage without collateral damage. I think that's the most important thing. And we know that biologicals are effective as well as safe, and we always compare them with the traditional treatments. And when we compare it with the traditional allergy treatments, which have been also spoken about, is respiratory allergy. In respiratory allergies is antihistamines, corticosteroids, local and oral immunotherapy, and they all are basically taking care of the symptoms of the patient. But what you need is something which can change the course of the allergy in an individual patient. And that's what biologicals can do. We are talking about remission from allergies now. So obviously we have moved ahead with biologicals beyond symptom management, beyond control of disease, beyond decreasing the burden of the disease on the patient, to something like as if the allergies never existed in that individual patient. I think that's the dream come true, which is we are realizing in asthma, and I'm sure it would be seen in all other allergies too, considering that they are not only very, very effective, but they are becoming more and more specific and targeted, with the newer molecules showing much more promise than the initial ones, which were little more broader in their concept as well as in their I think designing. I think biologicals are designed therapies. They are designed therapies. And beautifully Shalini had shown all the molecules which are there, and how one molecule is not the only one responsible. Like invariably there will be many, but some patients will have one particular cytokine which is more importantly playing a bad role or a villain's role, while others might be just innocent bystanders. And that is what are called as super responders. You give them the treatment and as if the disease was never there. But yes, there are others who are responders, and there are a couple of them who are non-responders. So when we talk about biological therapies, they are effective across the range, and obviously those who do not respond to one, we try with the other, as again Shalini has shown that maybe there is another cytokine or another cell, or the cytokines targets are so different that you can't be perhaps obliterating all of them. The effectiveness of comparison is primarily to look at those patients who are not responsive to the traditional treatments. You offer them something which is above that, and that is biologicals. And they do provide significant relief as well as quality of life, with an ambitious goal of cure. Now, I'm going to talk about cost of the biologicals, and I am only trying to concentrate on O'Malley, Mepo, and benralizumab, and maybe dupilumab, because I know the allergy circle is very, very excited to get dupilumab, because there are a lot indications, and of course certain skin as well as other conditions are really very responsive to dupilumab, and they have done wonders with that. So generally the factors which are responsible for use of omalizumab is serum IgE and weight. So you need to have above 30, and of course the weight has to be where you can't go beyond the 150 kg, or at which you cannot neutralize the IgE enough, because the weight and serum IgE are the two factors for that. Mepolizumab, multiple comorbidities; benralizumab, multiple comorbidities; and dupilumab, very specific indications. If you look at the cost of therapy per month, the most expensive biologic is actually a dupilumab, and the least expensive is omalizumab. But it would not be right to say, because the dose of omalizumab is dependent on IgE and weight, and a lot of patients will require many more injections rather than one injection of 150 milligrams. So if you look at the unit cost in India, so I think it's like $850 to 8,500 rupees. Definitely dollar is not 10 rupees, but that's what it is looking like out here. Very cheap. Then when we talk about mepolizumab, its cost is 67,000 rupees, and obviously that's per month. And benralizumab is 2.25 lakhs. I think this is again one of the most expensive ones which are available here. And of course we don't have dupilumab. We have tried to calculate it that if the patient has to pay from his pocket and is not covered by any insurance, then what would be the cost of it? So the cost of O'Malley is about 8,500 to 55,000. Most of the patients will be settling around 30,000, because their IgE will be high or the weight will be high, and we will be using about 3 vials, which will cost to somewhere around basically 30,000. So same is the cost for mepolizumab, and same is the cost per month therapy for benralizumab. So practically in India, the cost of all 3 biologicals for a patient, individual patient, would amount to same if he is paying from his pocket. Then it depends upon their indications. Like we have discussed enough about omalizumab. I will only talk about mepolizumab and benralizumab, which are approved not only in severe eosinophilic asthma, but now both of them are approved for EGPA also. And of course, yes, we have them also being used for nasal polyposis as well as chronic rhinosinusitis, in which situations post-surgery. But it will be invariably associated with severe eosinophilic asthma, where you will be using it rather than for the disease per se, which is of the upper airways like rhinosinusitis or nasal polyposis. Cost analysis, that's a very important thing. When we start talking about biologicals, the first bomb which is thrown on me is like, it's like very expensive. How can the patients afford it? Yes, we know that there is a higher initial cost. They come at of course, a very premium price, but they also come with higher impact, which is going to be on overall quality of life of the patient, which is in the term of long-term benefits. So higher upfront cost of the biological treatments need to be balanced with the overall healthcare utilization, which is going to be much lower, because these patients are not going to come to our OPDs, our ERs and our emergencies repeatedly and recurrently. So the comprehensive cost analysis, which really need to look into what you are giving and what you are getting, I think will be ultimately a potential savings on the part of reduced healthcare expenses, which are hidden most of the time. And of course, we don't account for that because we don't consider that important in our discussions. How do we navigate the cost in the healthcare system in India? I think this is the question which right across the entire Southeast Asia, where there is no uniform insurance policy of the population, ask this question again and again to me. So we definitely need to consider the cost, because cost versus benefit analysis is required. Indian scenario is very peculiar. We have free Medicare by the government, and these are basically only for the senior citizens, in which those who have worked in the government sector for their lives, they will be covered for all these kind of biologicals which we use in patients with respiratory allergies. Then we also have a government insurance to working and retired employees, as well as public sector healthcare support, which is given to not only their employees but to their families also. And they are all covering biologicals now. ESI, which is there for the small industries, also cover their employees for these biologicals. And then there are private insurance companies. These private individual insurances have now started covering, and all of them actually give them upfront approvals to use biologicals in these patients, because they are the ones who have finally realized that if their admissions are reduced, if their hospitalizations are less, they are going to be definitely saving money rather than giving only for the emergencies and admissions and things like that, and not paying them for the biologicals. So almost all private individual insurances covered by the this multinational insurance companies is now covering for the biologicals. But still, there is a very good chunk of people who do not have insurance, who have never worked in the government, nor in the public sector, or covered by the ESI. They need self-finance Medicare, and that is where I think the painful point exists all across the countries, where we do not have a uniform insurance as to how to give this benefit to this group of patients. It pinches a lot. Looking at the factors which are perhaps again very important, considering that what are the factors to be considered for the cost? So we talk about the drug, and overall the cost of the biological treatments is very high, but biosimilars have come not only in a great way, but very importantly, I think we are almost at the verge of getting other biologicals also getting approved in the biosimilars. So I think biosimilar will be drug pricing cut, which is going to happen in the near future. Insurance coverage is definitely going to increase much more, because now there are insurances which are actually giving an insurance to people who have pre-existing asthma. I think this is a sea change. Previously, anybody with any history of asthma could never buy an insurance, and today they are able to do. And not only they are able to do, but within 1 year they are able to start with their biologicals also. Why not to give all these kind of benefits to your patients who desperately need it but can't afford it? Patient adherence is definitely an issue, and that is directly related to the cost of the biological therapies. And this ultimately will lead to increased healthcare costs. So I think counseling the patients is very important. But today there is a different area. The medical costs have soared so much that I think we are almost competing with the United States as to how much one has to pay for a good health policies as well as the good health care provided by the big hospitals. So how can you cut the corners by in fact to decrease the cost of the therapy? So patient education is very must. Adherence is very good required, and it's very important that the patient should understand the treatment plan and manage it accordingly. You talk to them and they say, okay, I want to take, and they take one injection and go away. I think it's a waste. There's absolutely no point of doing those kind of things. Let them think, let them decide, and then let them plan. And then when they come with the full kind of a commitment, then of course management is going to be much easier. And we can navigate through the insurance benefits wherever it's possible to reduce the out of pocket. Some of them are on co-payments, where also we try to cut corners by trying to navigate in such a way that they have to pay minimum from their pocket, and most of it comes from the insurance benefits. Patient assistance programs, I think this is a very important thing for all of us to understand, that all these companies have got patient assistance programs. If our patient is really very poor, cannot afford it, we really need to go and talk to them about the financial support for this assistance program, which is in fact a part and parcel of all these new drugs which come into the market. This is a study which we tried to look into asthmatic patients, 100 as consecutive asthmatic patients, and the most important thing was that 30% of these patients had both signals of T2 inflammation, that is IgE, as well as eosinophil. And we have omalizumab and we have anti-IL-5 drugs. So which one to choose has been not always, I think you need to be very, very precise in being correct at the first time itself. Our patients are not forgiving for mistakes in our choice of biologic, because even 4 months of therapy is like too much to be lost by the patient if they are paying from the pocket. So we need to be more cautious when we use biologicals to not only cut the cost, but also to see that we don't lead to failures. We all know that nearly 70 to 80% of patients do respond to biologicals when we use, but in India it is almost to 90%. And the reason being, we are very, very choosy, where we want to be very sure that the biological will work. So on the other way, it would mean is that perhaps we are losing quite a lot of them who might also benefit. So I think we need to broaden our horizon of thinking and offer the patients and let them decide. I think we should not take the onus of decision on ourselves. We should actually give the facts and let them decide whether they need it or not. So in our study, we found nearly 50% of patients were eligible for both, actually IgE or one of the anti-IL-5, or as far as anti-IL-5s are concerned, all the patients who are eligible for mepolizumab are also eligible for benralizumab. There is a very little difference between eligibility criteria of these two drugs, besides the age factor, which of course mepo is available now for the children, and benra is not yet approved for above the 18 years. So best fit biological right at the beginning is the most important thing to reduce the cost of the patient. So you choose it very, very appropriately, and 3 factors are very important to choose an appropriate biological. What is the age of onset of asthma? If it is childhood, O'Malley works generally well. If it is late onset in adulthood, it is mepoli. And a quite late onset ones above the age of 50 or so, or the patients who have a long sufferings, actually do respond to benrali very well. Second is what are the biomarkers. So we know that a specific allergen positivity, IgE level, FeNO levels, as well as body mass index is a very important biomarker for omalizumab. On the other hand, for mepolizumab, we have pheno-eosinophils as well as sputum-eosinophils, and same is biomarkers for the benralizumab because both are anti-IL-5 drugs. But the comorbidities due to T2 inflammation, which I think all the three speakers who spoke before me had brought very clearly and spoke about not only allergic rhinitis, chronic sinusitis, nasal polyposis, idiopathic urticaria, food allergy, nasal polyposis, hypereosinophilic syndromes, and eosinophilic gastritis. But very importantly, one more thing which in asthma matters is the airway mucus. And mucus, I think, is so beautifully elaborated by Shalini, is that it is again an interleukin driven production, and anti-IL-4 or anti-IL-4/5 blockers are very effective in taking care of mucus in patients who have severe asthma with mucus impactions, and benralizumab is again shown to be effective in this group of patients. But at the end of the day, patient preference, cost, reimbursement and dosing is a very important factor, because some of the patients don't want to come twice a month, some of the patients don't want to come once a month, and you really need to choose that which biologic suits them best as far as their schedule and convenience is concerned. Then comes the second part of my talk, which is monitoring the progress and effectiveness. So very regular follow-ups are required, and they need to be structured, where you really need to look into it. How is the patient progressing? Tracking the improvements in not only the general or the global assessment, which is commonly used for the omalizumab, but very specifically with the hard points like asthma control or nasal symptom control or exacerbations, quality of life, OCS use, reduction of maintenance OCS. All of them are hard points to be followed at each follow-up visit. The compliance is again to be evaluated and of course to be correlated with the symptom control as well as the overall improvement in the patient. The treatment decisions have to be always informed, where the patient should know almost everything. Monitoring where is very vital, and this informed decisions about ongoing treatment plan and intervention should all be discussed in advance. Failures are also discussed in advance, that in case it happens, what are the options available and how are we going to exercise that with the help of informed decision from the patient as well as the patient's caregivers. Of course, follow-ups also means to look at the safety monitoring. Although there are no major issues reported with any of the three drugs, we have used them extensively, all three of them, and very, very comfortable in giving them in the OPD and now at the home. Then comes when the patients come for the monitoring visits, what all you look at it and at what time you need to look at it. So classically, since omalizumab came first, and omalizumab is a IgE blocking antibody, and most of the effect comes by 4 months. So all the biologicals assessments are generally done at 4 months period, which is considered as the minimum period. And what you look at that point of time is how much is the symptom burden reduced, has the exacerbations reduced, the treatment side effects of the drug you are using as well as OCS must be documented. Lung function improvement again needs to be looked into and documented. And very importantly, when these patients are started, particularly in asthma or other allergies, they are on board with like polypharmacy. They have so many drugs they are going on, which is called as high level of treatment intensity. And we need to see that how many drugs we could actually tick off from that because of the biologicals, which we consider them as useless. In asthma, as per instance, I can tell you that all these derifilins, doxyphilins and acerbrophilins and montelukast and azithromycin and all those other drugs, mucus producing N-acetylcysteine and things like that, all are absolutely actually knocked off by the time the 4 months are there on biologicals, and they are purely on ICS LAVA, and many a times we even take off the tiotropium or anticholinergics from them, and they are only on medium to high dose ICS and LAVA. So a significant reduction of a treatment intensity itself is a very good indicator of a response to biologicals. And of course, at the end of the day, patients' satisfaction and concerns are very, very important. So what happens at 4 months if the patient shows a poor response? So patient says, I am really not doing well, and I do not know what's going on. Most of the times at this point, you either need to stop the biologic or to switch to something else where you might feel that the other group might be more effective. So you have only choice of interchanging between omalizumab, mepolizumab and benralizumab. We don't have dupilumab, which would be the next choice in such patients, but now of course tezepelumab will be the one, which is showing a very good promise that although failures will perhaps do better on that. Then comes the unclear response. So patient is like, doesn't know that whether he's doing good or not, but he feels that he's better, but not as good as he would have expected him to be. So in those cases, we extend this for almost 6 to 12 months. And if they continue, because it's been shown in the data that those patients who show partial response at 4 to 6 months will show a much better response over the 12 months. So we continue that. One question which comes to mind is, why do biological responses inadequate in an individual patient? And that is a question which you need to answer to the patient as well as to yourself. So there are early failures, like these patients will come within 3 months and they say that I continue to have exacerbations and continue to use maintenance oral corticosteroids, I'm requiring bursts of OCS. What is happening there? So this is basically a baseline fault. So whatever biological was chosen for that patient was perhaps not matching to the cytokines or the so-called as the inflammatory pathways of asthma in that individual patient. The other group is the late failure. They start with the therapy, they feel very good, and after some time, over a year or sometime year and a half, they've started to show that they are failing in their treatment. They develop, the symptoms back again, exacerbations, they require OCS. What is happening? So we call it late failures, and most common cause is resistance. And resistance can be manifested in the form of airway eosinophilia. So there may be, the blood eosinophils are not high, but this is the time when sputum eosinophils will show high levels. So there may be also developing neutralizing antibodies to monoclonal antibodies, which most of the times is generally less than 5%, not significant, but in maybe some patient it is there. But since we do not check them, we have no facility to do that. So perhaps it can be clinically suspected as a reason for late failure. And of course, multiple comorbidities, which if they do not respond to the biologic, may be responsible for a poor quality of life of the patient. So a patient with sleep apnea may be badly having a quality, will be having a bad quality of life primarily because of his non-compliance to CPAP, not because the biologicals didn't work. So we need to consider that all comorbidity burden which comes with it, with the severe asthma patients, how many of them are troubling the patient with producing symptoms which cannot be controlled by the biologicals, and we should not be looking at them as the index indicators for the improvement after the use of biologicals. By and large, 20% of patients do become refractory, and they need to be looked into that way. But the good news is that if they fail, you can switch the biologicals. And this is the study of 58 patients who were either on omalizumab or mepolizumab or a combination of omalizumab and mepolizumab, which I think Karthik was alluding to in his discussion. These patients were switched to benralizumab. And if you look at it, those patients who, after the switch, they almost showed 90% and above response. So what it means is that switch is not only safe, but it is effective and possible. Only thing is you need to go to a higher level of a biologic, which is, and higher level practically means the one which comes late into clinical research as well as availability to us. At the moment, I would say that tezepelumab is the one which is the like on the top at the moment, and we expect it to be there in India maybe in a year or two. Then comes the adjusting the therapy plans. So patient's evaluation, and the monitoring is very crucial for making necessary adjustment. What kind of necessary judgment? So Sunita had spoken about it. Spacing is something which we do very often. So the dosage is not reduced, and I have never done it for even omalizumab or any other drug, but we try to space them. So if they have to be given like 1 month, we go to 1.5 to 2 months, and then make it 3 months. And we are watching that we do not lose the control of the disease which has come because of the biologics. Switching therapy is again one of the option when the things are suboptimal. I have already discussed it, and sometimes additional therapies need to be discussed and added on to it. And I think allergy and immunotherapy in combination with biologic is definitely one of the fields which needs to be explored more in future. So therapy duration, how long to continue? So previously we used to say that, it's going to be for lifelong. We have patients on omalizumab for almost like 14 years, 15 years, even more than that. But now we don't discuss this duration of that long duration. We talk about 2 to 3 years in this patient. But it also depends upon individual response. Some of the people respond very well, and even after 1 year, when they leave the treatment, they remain as good as they were on treatment, and they don't lose control of the disease. Severity of the disease also has an impact, where the duration of the therapy would be required a longer period, because some of our patients are so bad that their lung functions are almost to the tune of 30% or 25%, and these patients will definitely take a longer time to recover. And of course, you need to do regular assessments and evaluations, which is very crucial to look at the efficacy and safety of the biological treatments in the patients, and keep discussing with them so that they are also tuned to what you are doing, what you are planning, and what they have to be actually prepared for in the future. So I'll conclude here. The advancements in treatment is biological. It's a mark which is a significant advancement over the period of time in the last 25 years over the respiratory allergies. Cost implications are high because these are brahmastras. So obviously these are very, very expensive at the moment, but I'm sure that biosimilars is the way forward. Duration of therapy, when we talk about, at least we have now some data in asthma that 2 years is the time where we can really turn the switch off and observe those patients who remain well, and those who do not can be reinitiated also. So real world application is the most important thing to be considered as to how to provide these all biologicals to the patients by mutual care decision, mutual making decisions with the caregivers, with the patient, their healthcare providers, as well as we who are ultimately responsible for taking the care of the patient. With that, I would like to thank you all, and we have a couple of allergy sessions, so if anybody is interested in our pulmonologist or pediatric pulmonologist, invite them to Octane PAX 2025 happening on 15th, 16th, 17th August at Delhi. Thank you very much. You can get information by going to www.paxfoundation.com.
Thank you very much, sir, for enlightening us and giving us this very difficult answer after researching and all. Because in Indians, they need everything. अभी नई गाड़ी आई तो उसे पहला क्वेश्चन रहता है कि वो कितना देती है. That is the answer people wants in India, and people have used omalizumab and others for stabilizing the patient initially, and they started on immunotherapy and all. So they work. What do you feel, sir? And then switching over to the whatever the therapy. Because many times there is exacerbations.
Sorry, I didn't get the question. So you are asking about
No,
immunotherapy?
the people have used about omalizumab and all. Many of them for stabilizing the patient means that they get symptomatic relief fast. And how fast you get a relief, and they continue with whatever inhalers or immunotherapy or patient has, and then it
So
can be removed
correct.
earlier.
So with omalizumab, I think stabilizing the patient was the most important thing, and particularly for allergy specialists, because they were not able to give immunotherapy to these patients. So that's how it was used primarily initially, and later on it was realized that we are not only able to stabilize the patients, but they do feel much better. But with omalizumab, there was an issue that, at that point of time, the duration of the therapy was lifelong. And we had no idea as to, what happens to these patients who stop, because there were data which showed that even after 5 years of stopping the omalizumab, there are a group of people who will start deteriorating again once you stop it. So there was no spacing, there was nothing, nobody knew what to do. So there were little difficulties at that point of time. However, now we have a more data, and it is showing, a very good data that these diseases are actually, these biologicals are actually modifying the disease itself. So the disease is becoming now less virulent, less severe, and the patients have started feeling like as if they never had the disease. So that is where it makes a lot of difference. But when you talk about immunotherapy, I think the most important thing is they have a different principles working together. And I think to cut the cost, if you think about combining the two, I don't think so there is anything wrong in it. And obviously the data is also there to support it that you can actually combine. Only thing is, we in India use biologics in very, very severe patients. So in those cases, to use immunotherapy would be perhaps not a good option.
Thank you, sir. So, there was one question from you. I think you answered it actually. When to consider a biologic therapy is not helping and should be stopped in a given patient? Said
Perfect.
after 4 months time you can assess.
If at 4 months you find that this patient comes back, like I had today one patient, he has completed 4 months and he said, I have no effect at all. So I told him that there's no point in going ahead. And then he came back to my office and told me that, sir, I want to try for 2 more months and see it might work. So people have, different perspective at all, because I think society gives a lot of information to them about biologicals, which they try to assimilate in their minds and think about whatever they want. But reality is that it's not zero. It's like it's partial response. And if it's a partial response, you continue. But if the patient says that he has got no benefit at all at 4 months, we need to switch. And this we tell the patient upfront that there is a possibility that you may not respond to this, and we might have to switch the patient, especially in the overlap group.
So a lot of people wanted to know about when is your take that Dupili will come here.
So this question I think Sanofi should answer. I do not know. I'm all the time discussing with Sanofi people, but when I looked at the pricing, so it's supposed to be the most expensive drug in the US even. So I think maybe pricing is the major bar for bringing it at the moment in India. So they have permissions for atopic dermatitis, but I do not know. But if we get Tezi before that, then I don't think so that people will be even that impatiently looking for duplimumab. I think they'll miss the bus.
When we should get a biosimilar sort of all this, like in 5, 7, 8 years,
That's a
more than that,
very difficult
your
question.
take on it.
Yeah, I think it's a very, very good question, because I desperately want that, anti-IL-5s should get into biosimilars. I know the work is going on, and I know that it's not going to be easy also. And once it comes, then obviously it will be a game changer, because it will be definitely very, very cheap in comparison to the other drugs like the mepolizumab, which is available, or benralizumab by GSK and AstraZeneca.
So one question is, and others also can answer, is the pediatrics usually, can we start a biological in steroid inhaler refusing patient where there is no clear-cut indication in guidelines, but they are refusing. There's nothing else. You have to give them all, they go for heavy metals in homeopathy and all the other things.
Dr. Danish, I think it is already being done. It's
Yeah.
already being done. And with Sir, we have been, I've been part of a severe asthma clinic for such a long time. And believe me, the requirement of biologics has been really, really very less, in children. If you control the asthma, comorbidities, alternate diagnosis, and the right therapy, the requirement is very less. And I believe that it's being overused in our country already. and promoting it as something steroid sparing or something that is the first line treatment would not be right at this juncture.
Yeah, not as a steroid sparing, but steroid refusing inhaler therapy. Okay? Those who are refusing inhaler therapy. That's a right line of treatment, actually.
I don't know about children, but yes, in
Yeah,
adults we do get such kind of a request, particularly those patients who have got bad eyes, because
yeah,
the
Yeah.
ophthalmologist tells that the cataract has already been operated upon. Now it is increased intraocular pressure, and they are bothered about ICS to be stopped by all means. So one of the times when patient came and asked me that is there a drug available which can be actually substituted for inhaled corticosteroid? And I really looked back and tried to look into literature and did find references to that. And I did tell him that yes, this is a drug which can do that. And he immediately jumped into it. And he's on SOS inhaler right now. And this is the data from Shamal's study, which shows that after 1 year, almost like one third of patients who received benralizumab actually from step 5 went down to step 1. They were just on ICS and LABA or ICS or SABA SOS inhaler. So if that can be, if the data is suggesting that, why would I say no to them? If they want, yes, it is possible now. Everything is changing in asthma.
What's your experience, Dr. Karthik or Sunita, in this
So yeah, very
renditions?
similar things. And actually, just yesterday, I had a similar question from a patient who said that their ophthalmologist has told them that they have a raised intraocular pressure, so that they have to avoid intranasal spray also. So now it's not even a question of inhaler use. Even an intranasal steroid is also to be avoided, is what the recommendation was. It was difficult to communicate with this patient at that point of time. So yes, we did discuss about all the options available, including the oral options like leukotriene receptor antagonist first, as all that beginning from there, going up to an anti-IG. We do discuss. I have had to. I was like forced to use because the patient was so vehemently opposed to using any form of inhaled steroids. So at that position, we had to use omalizumab for a patient who had probably mild to moderate rhinosinusitis with asthma. So that was a scenario where, out of our forced effort, it was required at that point in time. The patient did improve, but now again we're looking at a question: can we stop it? So that's another discussion we'll have it later. But this is something that patients are coming up with recently, particularly like sir said, ophthalmology. Those who have already had an ophthalmology consultant come to you, they are the ones who have this query. I think we have to get into
Okay.
it.
Yeah. So the one final question for you and experience and others to you that omalizumab doesn't have a much risk of anaphylaxis. It's very minimal. So your take on giving it in a standalone clinic, not in the hospital.
So sorry, sir. Sir, Deepak sir was saying.
Okay, I just wanted to say that we have never seen an anaphylaxis. Patients, attendants are giving injections at home also. So I think the first injection which you want to give it in the hospital, you carry on with that protocol. But after that, it is really not required. We have never ever seen any anaphylaxis with omalizumab or biosimilar, whether it was Novartis or now it is the other ones which are available. None of them has caused it. And in fact, today I had one patient whose son told me that omalizumab I am giving myself at home. Actually, I am not calling even a nurse.
Yeah,
So one
yes,
thing
sir.
that
But the protocol, I think Dupili and all, they have allowed to give it home. They don't have anaphylaxis. But here,
metabolism.
yeah, and the first one you have to observe for how much time? For 2 hours or half an hour and all. First dose.
Recommended is 4 hours.
Yeah.
Tell them 2 hours, but they become so impatient that they leave within 1 hour actually because they're happy. There's nothing wrong. But I want to tell one particular thing. Since Karthik was very clear on this to tell us that dupilumab is totally human. It's not supposed to produce anaphylaxis. But in fact, the studies have shown that the allergic reactions to dupilumab are as common or as good or as bad as the other biologicals. It doesn't make a difference at all.
Yeah, because I've read that US FDA has approved it to give it at home.
So at home, even
Dupilumab.
at home, mepolizumab and benralizumab is also
Yeah.
approved, and omalizumab also with auto injectors. that patient can inject themselves. They don't need actually even a nurse to do it. Only first
Okay.
injection under observation.
Yeah. Just put two, three remarks what I've read. So one has got, can we use biological therapy for getting control before starting allergen immunotherapy in asthma and then stop in between when patient is symptom free? Yeah, we said it's okay. We answered it. Then another one was, can we biologically mild to moderate asthma if patient wants to get rid of inhaler? That also we have cleared. The third one is someone asked here, many times patient don't want to use inhalers for long time, so can we consider biological in mild to moderate asthma in that case? Yes, if they want to give up everything, we have cleared this. I think anything else, any message you want to give any one of you or all of you, anything? So,
I would want to reiterate that yes, in those cases, biologicals can be the answer. But as Dr. Sunita said, allergen identification and immunotherapy will give you a longer benefit. So give
yeah,
both, not just one.
so catch them early and treat them properly. That's a better. Then there are biologicals always are there. Okay? Uh, okay, so with that, we will conclude this session. Thank you very much, Dr. Talwar sir, for your very much experience, input, everything. So, Sunita, for so much of work you've done on your cases and all, and wonderful initial part given by Shalini, and as usual, Karthik is inside and all. So, thank you very much. We will. Say goodbye. Thanks to Dr. Neeraj, Dr. Narayan Reddy, and everyone else whoever joined today. Thank you.
Thank you, everyone.
Okay.
Thank you,
Well,
everyone. Thank you for inviting
yeah,
me. Thanks a lot.
yeah, yeah. Thanks, sir. It's always pleasure to listen to you. So many times, every conference we have
Extremely
listened it every
satisfied,
this thing.
extremely happy, but it was a very difficult topic given to me. Very, very difficult.
Yeah.